What's up, good people? Today I'm going to talk about a very important and very crucial thing because there are many people in all the parts of the world who have got something called OSA or obstructive sleep apnea, and that's a huge problem in a population, especially those who are obese, because they tend to snore, and during that whole process, some people don't even snore and still they can have OSA, just so you know. But majority of them do snore, and during that whole process, they have low oxygen level in their blood, and therefore some very important and critical structures in your body are impacted and negatively impacted. And one of those critical structures in your whole body is called eye, and inside the eye a very important and the most crucial thing is called optic nerve. And that optic nerve in those OSA patient or obstructive sleep apneic patients is affected, and that thing leads to glaucoma. And glaucoma is one of the leading causes of blindness. It's not the top one, but still it's one of the leading causes of blindness in the world, all over the world. And there's a strong association between OSA or obstructive sleep apnea and glaucoma, so you need to be careful. If you have tendencies to snore, or if you're obese and you have daytime sleepiness, please talk to your doctor and get your eyes checked, because no wonder you might be heading towards glaucoma. So it's better to get your eyes checked anyways on annual basis. But if you are one of those people who have got OSA, or who snore, or who have the symptomatology of OSA, please check with your eye doctor so that you don't fall into a problem that can lead to blindness, and that problem is called glaucoma. Let's go over a very good publication about it. I found out this thing, and I'm gonna share this link in my description of this video, so feel free to read all of it. I will go over some of the major points or main points covered in this, that OSA is one of the systemic risk factors that can lead to glaucoma, or that's connected to glaucoma. Again, it's a correlation, and that could turn into a causation. That's why they're saying it's a risk factor. Some people confuse it by saying, oh yeah, it's just a correlation, but it's not a cause of glaucoma. Yes, I understand, and not everybody with OSA is gonna get glaucoma, but it's a huge risk factor that can lead to damage to your field of vision. And if your field of vision is compromised, you are heading towards glaucoma, and eventually glaucoma can lead to blindness. That's why I am extremely concerned about my people I see and my people that I talk to. And what happens in this is because there's thinning of R and FL, which is retinal nerve fiber layer, and alteration of optic nerve head itself, and choroidal and macular thickness is also affected, and you see reduction of visual field. Your field of vision is reduced. And let me tell you, when you go for a driving license, or when you are disabled, this is one of the criteria that we look at, the visual field, that how much field loss do you have, are you a disabled person or not, and so on and so forth. So we do see diurnal fluctuations of IOP, and that's more variation in the OSA patient. In every person, there is some diurnal fluctuation of your pressure of the eyeball itself, but that fluctuation is more in OSA patients. And after continuous positive airway pressure therapy, which is CPAP, we see that when compared with the normal cases. So we do see that diurnal fluctuation in OSA patients both before and after the CPAP therapy. It's a positive airway pressure that's going in your body so as to keep your airways open, so that your blood oxygen level does not drop. So in conclusion, glaucoma evaluation is very important. It is recommended, it should be recommended in those patients who have got this thing called OSA and should be periodically monitoring their IOP during the CPAP treatment as well. So if you are getting CPAP treatment, it is still extremely crucial to get your eyes checked and to get your eyes examined, especially with IOP check and optic nerve evaluation, because sometimes the CPAP itself could also trigger the progression of the glaucoma damage. But that does not mean that you stop taking CPAP, because if you stop taking CPAP, that is going to put your nerve at risk. So the conclusion is you do both. What both? You get yourself treated for OSA and you get yourself monitored for your intraocular pressure, which is IOP, and you get the monitoring for your RNFL. If you go to your eye doctor, he's gonna do RNFL analysis, he's gonna do your optic nerve head evaluation and tell you where you are at and what you need to do. So there needs to be a correspondence between your eye doc and your pulmonologist. That's all I want to tell you guys here. And let's go over briefly over this publication that yes, OSA, you see recurrent, complete or partial interruption of the normal breathing while you're sleeping, while you're snoring, due to the functional occlusion or collapse of the upper airway during the sleep, that leads to the apneic spells or hypopneic spells or hypoxia, and that leads to decrease in arterial oxygen saturation. And that's why you end up having some glaucomatous optic nerve damage, because the optic nerve needs its nutrition and it is extremely sensitive to low oxygen saturations, and that's why it can lead to compromise in the oxygenation of your optic nerve head. Okay, and that's why if you look at the pathophysiology of glaucoma during OSA, you see that you have hypoxia, which is decreased oxygenation in your blood, which in other words is PO2. Your PO2 drops down during that OSA spells or apneic or hypopneic spells, and that leads to or causes the hypoxia, which will cause the oxidative stress and inflammation by increase of the reactive oxygen species and inflammatory markers, and subsequently leads to mitochondrial dysfunction of the retinal ganglion cells. And that's why you end up having glaucoma, because your ganglion cells are getting compromised. Why are they getting compromised? Because your mitochondria is getting compromised. It cannot do the electron transport chain process in it there, and that's why you're heading towards the damage, and that's what leads to this thing called glaucoma, because glaucoma is the end result. But the problem with glaucoma is it leads to blindness, and you do not want to head into that. You will not head into that. Let me tell you, let me be very clear. I have seen a lot of patients who have got OSA and they are on CPAP, but they get irregular eye exams, IOP or intraocular pressure monitoring, and they are perfectly fine. So I'm not trying to scare you people. I'm just trying to educate you people in a positive way that yes, you need to be aware of it, but don't be afraid of it. Okay, vascular factors also play a great role in this, because there is definite vascular changes and vascular dysregulation at the optic nerve head, and that's what leads to further problems besides the hypoxic factor that I just discussed earlier, because the metabolic needs of the optic nerve itself are not met. And that's why we see the glaucomatous progression in these patients. And the prevalence, if you combine several studies, they have done a lot of studies on the prevalence of glaucoma in the OSA. Every study found a positive correlation. That's why now it's called a risk factor rather than correlation. That yes, it's a risk factor. CPAP is a risk factor. OSA is a risk factor. Both of them are risk factor. CPAP itself can also trigger, by the way, your oxidative damage. But again, there comes the role of your pulmonologist. He needs to make sure that your setting of the oxygenation levels that you do in your CPAP, the CPAP settings and the oxygen percentages, all those things, all those criteria have to be set very, very precisely based on your sleep studies. So talk to your pulmonologist about this. Some studies even go up to 27% of the prevalence of glaucoma in these patients who have OSA and they don't get treated. So be very, very careful and talk to your eye doctor, talk to your pulmonologist, and be an educated patient. That's all my purpose of this video is. My purpose is not to treat you right now in this video. My purpose is to educate you so that you go to your doctor as an educated patient and discuss with them that yes, you are my pulmonologist, tell me what should I do. You are my ophthalmologist, optometrist, please tell me what should I do. Where am I at this point? What's my RNFL? What's my optic nerve head strength? What's my visual field? How is it progressing? How is it gonna be next year? And things like that. Please ask your doctor about this because all the studies have shown that there is an increased prevalence of glaucoma in OSA patients, and it's associated with the severity. So the worse uh, OSA is gonna have worse glaucoma most likely. Again, it's not 100% thing. It's not 100% thing that a OSA patient will get glaucoma. So it's a risk factor. Just like every smoker does not get cancer and every cancer patient does not have smoking in his history. So it goes that way, okay? If you have more questions, please ask me in the comment section. It's a long debate. It's a long discussion. So I'm just trying to cut it short and make it very brief and precise and clear to all of you. But again, there will be a lot of questions. Please ask me in the comment section. Yeah, when you look at the RNFL, retinal nerve fiber layer, you will find out the thinning, and that relates to the severity of the OSA that I just talked about. So you need to treat yourself with the CPAP because if you are getting low oxygenation, low PO2, your pulse ox is running low, you are gonna have problem with the nerve fiber layer, and that's what is leading to your optic nerve head damage. And you don't want that morphological changes in your ONH, the optic nerve head thing, and the thickness in the macula. The macular scan will also show changes in the thickness over there, and we do not need that. We want to preserve your vision because we don't want you to go blind. Okay, all the things need to be maintained, and same thing goes with the choroidal thickness. Choroid is a highly vascularized tissue inside your eye, and that gives a lot of nutrition to the eye. But the problem is in the patients with OSA, you have seen that this thing goes thin and the supply is compromised, and we don't want that. We want oxygenation inside your eye. We don't want hyperoxygenation. That's why you need perfect setting of your CPAP. You don't want hyperoxygenation because if you have a lot of oxygen going on, that's also dangerous to your eye. That's why sometimes your glaucoma, normal tension glaucoma, could be triggered by the CPAP, and that's what's the conclusion of this whole study, of this whole publication. So moderate OSA showed reduced choroid thickness. That's what we found out, that OSA patients compared to control patients or those with mild and severe patients, they had reduced choroid thickness. So the goal is maintain the oxygenation of the eye to the best precision possible. And when you are looking at the visual field, we saw pattern standard deviation changes, we saw mean deviation changes, we saw a significant difference between the OSA patient and the control patient. So we saw drop in the visual field. We saw the drop in the sensitivity in the visual field, and we don't want to see that. We want you to have 100% field of vision. And when we are doing the electrophysiological studies, which are like visual evoked potentials and perk amplitude and latency, we saw a drop in the amplitudes. It's just like you're doing the ECG electrocardiography. We have electrophysiological study of this eye as well, and that we see as VEP and PERG study in this case. And when you see that, you will see drop in the amplitude, drop or abnormality in the latency. You see those abnormalities in the amps and the latent period or the latency period. So we have different waveforms, just like in EKG we have waveforms in the eye. The electrical study of the eye also gives us the waveforms, and we see them abnormal, and we don't want that kind of abnormality. That's what I am emphasizing here. Yes, get yourself treated with the CPAP, but make sure you do not trigger, because CPAP therapy may trigger the glaucomatous damage and its progression by raising the IOP. Okay, so talk to your pulmonologist and make sure the settings are done appropriately. So there needs to be a communication between your eye doctor and your pulmonologist, so that you have the best settings in your CPAP. You need to get yourself treated. I get this question asked so much that, yeah, I have a little bit of sleep apnea. My pulmonologist gave me this CPAP, and I need to put it every night, but I'm afraid that CPAP might trigger glaucoma. So that's why I'm not doing that. Brother, it's gonna cause a lot of damage. You can't do like that, because if you're not doing CPAP, that also increases the risk of getting glaucoma and decreasing the visual field and all those things that I was just talking. But another way, is the other side of the story is what the patient is telling me. Yes, that CPAP can trigger glaucoma, but if your setting is done appropriately, please don't be afraid of that, and stay in touch with your doctors. You have to have complete eye exam and regular visual field and optic nerve evaluation and all those things done, and you should be safe and sound. Okay, please like and subscribe and share to my channel, and talk to your eye doctor as well about these things. If you have any questions, you can ask me in the comment section, but educate yourself and educate others as well, because you want to prolong your best lifestyle, and you have to do that. And the purpose of this video is to educate yourself to that extent that you can take control of your health and be a very good educated patient. Thank you so much. Have a great day. Bye bye.